Okay, Sally again here. Let's talk about anti-inflammatories for a minute. We have two types of anti-inflammatories. We have the salicylates, which would be aspirin. This blocks the inflammatory response and inhibits prostaglandins. Prostaglandins, if they're not inhibited, causes inflammation and pain. So they are used for as an antipyretic, analgesic, and anti-inflammatory. However, we primarily use them for prophylaxis of TIAs and MIs. Okay, that is because of the anti-inflammatory response. We use the baby aspirin, 81 milligrams. And what this does is if you have a TIA, which is a transischemic attack, which is a precursor to stroke, or an MI, you get inflammation, which actually slows perfusion. And so by giving 81 milligrams of aspirin a day, it helps just kind of decrease that overall inflammation a little bit and can help actually protect the body from either A, having an MI or a TIA, or if they do have it, it can help decrease the effects of both the damage that a TIA or an MI would cause. The other classification is Nsaids, which are non-steroidal anti-inflammatory drugs. Some of these include ibuprofen, ketorolac, naproxen, and Celebrex. They also block the inflammatory response and inhibit prostaglandins. These are also good for rheumatoid arthritis and osteoarthritis. So I've got two here that I want to show you. First of all, the ketorolac. Ketorolac is an IV push. This is in a brown vial. So anything that comes in a brown vial, what you need to know is that that means that this is light sensitive. So you would just pull this up at bedside. Okay, this can be IV push or IM use. Majority of the time, I don't think I've ever given it IM, mostly IV. You would draw this up at the bedside because you don't want it in the syringe out to the sunlight or daylight or overhead light because it deteriorates extremely fast. Okay, so you want to push that fairly quick. It's not an NSAID, so you don't have to worry about respiratory depression or anything like that, and it works excellent. The other is there's Celebrex here and also ibuprofen. What we need to know about all of these, though, is except for the ketorolac because it's not a PO, all of the PO medications, what we need to know is that it causes bleeding and GI distress. So as you can see here, the nursing considerations are GI bleed. Whenever you think of the NSAIDs or even the salicylates, think GI bleed. That means that we need to monitor stool, sputum, vital signs for any signs and symptoms of a GI bleed. The vital signs, why? Well, we could be bleeding internally and not have any outside signs and symptoms of bleeding, but if we are bleeding into our abdomen, for example, then we will see our vital signs change via high heart rate and low blood pressure. We also have to assess, does this patient have a gastric or peptic ulcer? Because if they do, they're increasing again their risk of bleeding because these will bleed in themselves. And then adding NSAIDs or aspirin to the mix will just exacerbate the possibility of bleeding through these ulcers. We also want to monitor or even ward off the use of other medications that also can increase the risk of bleeding. So if we're taking ibuprofen, maybe we don't want to take ketorolac because it's the same classification, which increases the risk of bleeding. But then in the same breath, we want to monitor for our bleeding labs if someone is taking warfarin, heparin, or Plavix to prevent or help stabilize a blood clot. Education for the patient is to limit the alcohol as well. Alcohol can also cause a GI bleed. Monitor toxicity. So aspirin, for example, can cause tinnitus. So too much aspirin is toxic. Tinnitus is the ringing in the ear that you get. There's also some herbal interactions such as arnica, chamomile, garlic, ginger, and ginkgo. Many of these are very common herbal remedies, and so we would need to ask the patient about any herbal remedies that they take at home because it is a potential complication or interaction. In the hospital, they're not going to get these items, but when they go home, they might start taking their normal herbal remedies. Another non-invasive medication that we use is Tylenol. So we use Tylenol for pain. We also use it for fever. We don't use aspirin so much for fever, even though it is a antipyretic. But take a look at what this does. It acts directly on the hypothalamus and causes vasodilation and sweating. Well, vasodilation and sweating is what we need to decrease our fever. Okay, so it acts perfectly to decrease our fever. It's used for mild to moderate pain. It works really well. We do give this in the hospital for mild to moderate pain, whereas if I skip back here to our Nsaids, we actually don't give these very often. We give ketorolac probably the most because it works with orthopedic patients, but apart from that, you're not going to see Nsaids very much at all in the hospital because of the increased risk of bleeding. So we use Tylenol for mild to moderate pain. Also works good with RA, rheumatoid arthritis, and osteoarthritis for pain. Some adverse effects on here though is hepatotoxicity. We have to monitor their liver labs and we need to monitor while in the hospital how many milligrams of Tylenol we are giving them. Currently, it's starting to change. So currently it's still at 4 grams, but some hospitals have decreased that dosage because maybe I think they're finding that even lower dosages maybe are safer than 4 milligrams. So they might be seeing that there's some liver damage even with 4 milligrams if they're taking 4 milligrams regularly every 24 hours. So we have to monitor both the liver function and we have to count how many grams we're giving. Well, Tylenol for orthopedic patients as well is also given in an IV form right here called Ofirmev. I hope I'm saying that right. This is 1,000 milligrams of Tylenol that we give IV. And if we give that every 6 hours, that's 6, 12, 18, that's 2,400 milligrams. Oh no, sorry, that's 4,000 milligrams right there, just for those 4 doses. So already we're at our max. So we need to count how much because in our 12-hour shift, we can only give 2. And if they're in pain, they might be taking, you need to monitor which narcotics they're taking because if they're just getting morphine, that's fine, or codeine, that's fine. But if they're getting hydrocodone or Norco, which is a combination of Tylenol and codeine, which is a really good drug, it works really, really well. It has Tylenol in it. So if they're getting Norco, they probably can't get, or they can't take the Norco because this IV Tylenol is going to take up their entire dosage for the day. So we need to monitor that and make sure that our orders are correct so that we can manage the patient's pain correctly. Another adverse effect is Stevens-Johnson syndrome. You will see this. It doesn't happen very often, but you will see this. And it is a reaction to Tylenol, and it's actually a reaction to a fair number of medications as well. It's an allergic response. And what it causes is blisters, clear fluid-filled blisters on the skin. So you need to kind of watch out for that. Typically the patient will say, oh, look at this. I don't know where I got this blister from. So you need to take a look at it. And when you do your skin assessment, look at the skin and, pay close attention to this because it could actually be an allergic reaction that the patient is getting from the medication. In this case, we're talking about acetaminophen. Just call the doctor right away and they will decide which medication could be causing this reaction and will adjust their medications. So again, assess liver function. If we're assessing liver function because it's a hepatotoxicity, then they should not be using alcohol at all because this is hepatotoxic as well. And drug use as far as you know, either illegal drug use or opioids that are prescribed that have Tylenol in them. There's a lot of medications, even not associated with pain, that cause liver toxicity. So it needs to be, their med rec needs to be done appropriately so you can see what meds they're taking at home, and so that the doctor can come up with a plan that would best suit this patient. We're going to assess for over-the-counter meds as well for any interactions. Of course, we're always going to assess for pain prior to administration. If someone does overdose, comes into the ER, the antidote is acetylcysteine, which is given orally. If they cannot drink for some reason, then we can put it down in an NG tube. So we'll take the NG tube and put it to suction to take any Tylenol that might be left in their stomach out, and then we will give acetylcysteine, which is actually pretty nasty. It's a nasty taste, and it's just awful stuff. So hopefully that'll ward them off from giving themselves too much Tylenol for the next time. Okay, that's it for these anti-inflammatories and for the Tylenol, and next we will go to opioids.